Okay. Hello, good afternoon, everyone. So I'm Dr. Harika. Today we'll be discussing evaluation of male infertility. So in previous classes, doctors have dealt with female infertility and introduction to the female
Recording in
infertility.
progress.
Now we'll be discussing regarding evaluation of male infertility. So in generally, male infertility alone, it contributes to around 20% cases of infertility, and combined with female infertility, it will contribute to around 40%. So generally, basically coming to the etiopathogenesis of male infertility, we won't be discussing much about etiopathogenesis. In today's class, we'll be discussing only regarding the evaluation of male infertility. But before going to evaluation, let me discuss what are the causes of male infertility. So it will be divided into pre-testicular, testicular, and post-testicular. So pre-testicular is nothing but it is related to hypothalamus and pituitary. So any disorders associated with hypothalamus and pituitary, it will cause pre-testicular infertility, like any pituitary tumors, any infection. So it will cause hypo. So as a result of which, what will happen? The hormones which are produced from hypothalamus or pituitary, it will get decreased. That is, FSH and LH will be decreased. It will cause hypotropic hypogonadism. Okay, so we'll call it as hypo. Next, coming to testicular, it is within the testis. The pathology lies within the testis. Example, any varicocele. Most common is varicocele. Okay, or any kind of infections or trauma. Okay, and in few cases there will be cryptorchidism, undescended testis, torsion. Okay, and any inflammatory pathology. All these contribute to testicular causes. Coming to the post-testicular, that is outside the testis. So generally, what will be the outside the testis? Epididymis, vas deferens, seminal vesicles, ejaculatory ducts. So any pathology related to these, like seminal vesiculitis, it might be prostatitis, it might be ejaculatory duct obstruction, vas obstruction, epididymal infection, or congenital absence of vas deferens. So all these contribute to post-testicular. So basically, it is related to hypothalamus pituitary, hypo. This is related to testis. There are many other causes. Okay, but briefly, I'm discussing regarding causes of male infertility. Okay. Coming to evaluation. First is history. Next is examination. Third is investigations. So if you have any doubt, you can stop me and ask questions in between. So coming to history. Okay. So basically, history taking is very important. Okay. By taking history only, sometimes we can diagnose what is the probable cause of infertility. So first, history what will ask? Age. So age itself, it will indicate like cause of infertility. So what will happen as age advances? Suppose if paternal age is more than 40, okay, it might it is a reason for infertility, or if patient conceives also, she might land up in abortion. Okay, because as age advances, what will happen? Though the sperm quality is good, though sperm count is good, morphology is good, but DNA won't be the same. Okay, there might be damage in the DNA as age increases. So that might be the reason for subfertility or infertility. First utmost important is age. Next, occupation. So occupation. So if like he's exposed to radiation, continuous radiation exposure, or if he's continuously exposed to chemicals pesticides. Okay, all these also contribute to infertility. So that's why age and occupation are very important. Next is environmental factors. Okay, like exposure to pollutions, same thing. Okay, and next is lifestyle modifications, like lifestyle, not modifications, lifestyle changes. So if any person, like he is taking any substance abuse, like continuous alcohol intake, okay, or smoking or any substance abuse, it might also land up in infertility or subfertility. Next is we have to, utmost important is sexual history, because most of the males, they don't reveal. Okay, they don't reveal in the first visit regarding the sexual history. Suppose even if you have problem with anything like erection or ejaculation, he won't open up in the beginning. So that's why eliciting the history in the first visit is utmost important. So coming to the sexual history, what we should ask, first important thing is frequency of intercourse. Okay, so because if he meets once in a week and if he says that he is unable to conceive, that's not the proper case of infertility. So first thing is frequency of intercourse. Second thing is, yes, erectile dysfunctions. Third is ejaculated dysfunction. Any erectile dysfunctions or ejaculated dysfunctions. And next is whether he is using any lubricants. Okay, because most of the lubricants are spermicidal. So that's why we have to elicit whether he's using any lubricants during the time of intercourse. So first is like frequency of intercourse. Next is erection, ejaculation. Third is usage of any lubricants. And also fourth is like proper positioning. Okay, whether he's doing it in a proper position or not. Next thing is fertility history. So, what is fertility history? Like, we have to ask the duration of married life, okay, and any history of previous pregnancy, whether it is primary or secondary infertility, okay. And suppose if the duration of married life is more, okay, accordingly we can plan the treatment. And suppose if it is case of like secondary infertility, already previously she has conceived, okay, with the same male, then accordingly we can plan some other modes of treatment. So this is sexual history, this is fertility history. Next. Medical history, surgical history, family history, any medications. Okay, medical history. Like suppose example, whether he's having any medical problems. Okay, previous history of any medical problems like diabetes, hypertension, or previous history of any sexually transmitted infections. Okay, so all these also cause their indirect cause of infertility. Like suppose if he's having any diabetes mellitus, what will happen ultimately? He might suffer from erectile dysfunction. Okay, if he's a known case of diabetes mellitus. And accordingly, if he's having history of sexually transmitted infections, automatically that infection will spread to the female partner and she might land up in PID also. So what will happen? PID, the tubal damage will occur and it will land up in infertility. So any history of like sexually transmitted infection, or during childhood history, whether he suffered from any mumps, measles, mumps, rubella viral infections, all those we have to ask medical history. Coming to surgical history, so we have to ask like detail regarding surgical history, like history of any orchidopexy for undescended testes, okay, and history of any varicocele surgery, history of undescended testis, history of varicocele surgery, and also history of any hernia hydrocele repair. Okay, because suppose inguinal hernia, if doctor performs operation on inguinal hernia, accidentally there may be damage to the vas deferens. Okay, ultimately he'll land up in infertility. So any inguinal hernia repair, hydrocele repair, varicocele surgery, next orchidopexy, everything we have to ask the patient. Okay. Next, family history. few genetic conditions like Kalman syndrome, okay, cryptorchidism, all those runs in families, and also some kind of chromosomal abnormalities which might cause oligospermia or azoospermia. They might run in families, so that's why family history is also very important. Next is medications. So some people, they'll be taking prolonged medications, like example few antihypertensives, antipsychotic drugs, antidepressant drugs, few of the antibiotics, all these also they cause erectile dysfunction, and few they have impact on spermatogenesis. So and also few they might have harmful effect on sperm motility and sperm morphology, like cytotoxic drugs, chemotoxic drugs. So that's why taking medications, what medications he's using is also very important. So this is related to history taking. Everything is clear until now, doctors? So whenever the mail comes to your clinic, first you should maintain privacy when you take the history. So related to everything like age, occupation, habits like substance abuse, medical, surgical, past history, and occupational family history, and also main thing is sexual history and fertility history you have to take. Based on history only you'll come to know. Suppose his couple have been married for like 5 years. Okay, he is having erectile dysfunction, and in few cases they might miss retrograde ejaculation also. Okay, in such cases it is difficult to interpret what is the cause of infertility. So whether he is having erectile dysfunction, ejaculated dysfunction, there is no point in counseling for natural cycle. In that case you have to decide accordingly. You have to give him medications or you have to plan IUI accordingly. Okay, next, examination. So examination is, it includes from head to toe first examination. So first we have to observe height, weight, BMI. Okay, because obese males, what will happen? Generally, they'll have decreased testosterone production. Okay, obese males especially. So that's why, and we have to check height, weight, and BMI. Okay, to categorize types of obesity, grading of obesity. First thing. Next, what are the normal secondary sexual characters? Like axillary hair, pubic hair, and body hair, everything. So that is secondary sexual characters. So testosterone. So main hormone is testosterone, which will maintain the secondary sexual characters. Suppose if there is any sparse distribution of hair, that will indicate indirectly testosterone deficiency. Okay. So what will happen if there is any testosterone deficiency? Obviously, sexual drive will be reduced, libido will be reduced, and almost testosterone is the main hormone which is essential for the proper functioning of seminal vesicles, ejaculatory ducts, and all those. So, which will contribute mainly to the seminal fluid. Okay, if there is any deficiency of the testosterone, ultimately all will get affected, and ultimately they'll land up in infertility. So, basically by seeing the distribution of hair, if there is any sparse distribution of hair, and in few people what will happen, there will be loss of hair, loss of facial hair, loss of body hair, loss of axillary hair. That indicates that there is some problem with, okay, Leydig cells. Okay, because LH will act on Leydig cells to produce testosterone. Okay, internally testicular pathology might be there, and because of which testosterone deficiency has happened, and ultimately it landed up in decreased sexual drive. Okay, this is sparse distribution of hair. Okay, height, weight, BMI, sparse distribution of hair. Next, coming to breast examination. Breast and thyroid. Okay, what will happen like in few cases? Okay, where there is decreased androgen level and increased estrogen level. Okay, like in obese male and also in few other conditions, what will happen? Breast enlargement will be there. That is gynecomastia. Okay, so gynecomastia, it indicates in which abnormality gynecomastia you can see in which male patient. Yeah, in Klinefelter syndrome, they'll have gynecomastia. So what will happen in those patients? There will be decreased androgen levels and increased estrogen. So because of which there will be increased deposition of fat in the breast, which will cause gynecomastia. Okay, so we have to examine the breast. Thyroid also. Any history of like neck surgeries for thyroid disorders or any hypothyroidism, what will happen ultimately? It will affect the infertility because like TSH value and prolactin, these two hormones also, they'll affect the fertility hormones like FSH and LH. Suppose if there is any increase in TSH values, like in hypothyroidism, and also if there is any hyperprolactinemia, what will happen? It will decrease the LH levels. So obviously, it will cause decreased testosterone and decreased spermatogenesis. So ultimately, it will land up in infertility. So that's why ruling out thyroid disorders, ruling out hyperprolactinemia is very important. Okay. Next, breast over, thyroid over. Next, CVS and lung examination. Next, abdominal examination. So CVS and lung. So whether is known case of hypertension, okay, and whether is using any antihypertensive drugs, we have to make out. Second thing is lung examination. So see on simple auscultation, sometimes you can see for bronchiectasis. Okay, bronchiectasis. Why bronchiectasis is important? Because in some disorders like immotile cilia syndrome, okay, cystic fibrosis, they'll have bronchiectasis. You can see, and usually lung pathology is uses usually as young syndrome. You know, no, immotile cilia syndrome. What will happen? Ciliary movement won't be functioning and they'll land up in like most of the times sometimes azoospermia is also there and sperm motility will be decreased. One thing. Second thing is also situs inversus you can make out. Okay, there will be situs inversus. So dextrocardia you can make out on cardiac and lung examination. Okay, because I'll be discussing regarding cystic fibrosis in hormone evaluation. Okay, next is abdominal evaluation. So abdomen you can see any palpable masses and also you can see the scars in inguinal region. Okay, because that indicates previous history of inguinal hernia repair or orchidopexy surgeries. Okay, this is regarding the normal basic examination. So height, weight, BMI you have to make out because in few of the males, like on making out them, on seeing them, on noting that he is like obese male, what will happen? There will be like androgen deficiency. Okay, so testosterone will be less. So ultimately, if you ask them to control their weight, okay, if he reaches his target BMI, automatically the androgen production increases and ultimately the testosterone production increases and it will increase the sperm count and everything. So making few changes in their lifestyle modifications we can correct. Okay, because giving so many medications also doesn't correct the infertility problem. Okay, next is local examination. Okay, so local examination normally scrotum. So scrotum, what you'll see? Testis first. Next, epididymis. Next is vas deferens. Next is varicocele. And parectal examination is last. So generally, normally scrotum is like roundful. Okay, it is. So whenever you have to palpate, you have to examine male in standing position. Okay, so when you assess for testis, you have to see size of testis. Okay, and like whether it is present bilaterally. Sometimes in cryptorchidism, what will happen? Sac will be empty, scrotum sac will be empty. So you have to make presence of both sides of testis. One thing, size of testis, okay, and consistency of the testis. You have to see. Next, coming to epididymis. Okay, you can examine epididymis on posterior side and lateral side of testis. You can feel like whether there is any thickening of the epididymis. Okay, and also whether there is any inflammatory changes in vas also you can make out. And varicocele, okay, it will feel like bag of worms appearance. And this is basic examination. So whenever you examine locally, you have to see for scrotum. In scrotum, what you'll check? Testis, epididymis, vas deferens, varicocele. So bag of worms is varicocele. Okay, testis, whether it is present unilaterally or bilaterally. And if it is present, it is normal in size or atrophied size. Okay, and any epididymal thickening, vas thickening, everything you have to make it. Okay. Next, parectal examination. On parectal examination, you can make out seminal vesicles and ejaculated ducts. Generally, you can't feel, but it will be palpable only on parectal examination. Okay. This is local examination. And also for like whether there is any hypospadias, epispadias also, on seeing the phallus, you can see. Okay. Next is, this is regarding the examination. Coming to the most important thing is investigations. Till now it is clear? So coming to the investigations. So first most important thing is semen analysis. So how do we check the semen analysis? So WHO, it has past few editions, okay? Until recently, till 2021, we have followed the fifth edition of WHO, okay, in giving the sample report, semen analysis report. But from 2021, we are following the WHO sixth edition. WHO sixth edition and WHO fifth edition. It is published in 2010, it is published in 2021. So there are only like minute differences, okay? So according to these, volume. So lower limit, okay, we'll be discussing the lower limit. So when we see the semen analysis report, we'll categorize the semen reporting in few things. Like first, we have to note what is the volume of seminal fluid. Next important thing is concentration. Next important thing is motility. Okay, next morphology. These are the utmost important parameters. First is volume. Lower reference is 1.5 ml. According to recent edition, it is 1.4 ml. Okay. Next is total count. Minimum of 15 million count per ml. According to previous edition, now according to recent edition, it is 16 million. So for a woman to conceive naturally, the male should have a sperm count of at least 15 million per ml. According to 2010 guidelines, according to 2021 guidelines, a minimum concentration of 16 million is essential for a normal woman to conceive naturally. Okay. Next is total concentration, that is per ejaculate. It is same, that is 39 million in ejaculate. Okay. So this is, we are calculating per ejaculate, 39 million per ejaculate, and this is per ml. Okay, 15 million per ml, 16 million per ml, and overall volume is like 1.5 ml and 1.4 ml. Next, motility, total motility. Next, progressive motility, vitality. Okay, total motility is 40%. Okay, combined progressive and non-progressive motility is 40%. Next, progressive is 32%. So according to recent guidelines, total motility, it should be 42%. Progressive, it should be 30%. Okay. So generally motility, it is categorized into three things: rapid motility, okay, progressive motility, non-progressive motility, and immotile. So total motility is, we will combine both rapid progressive, slow progressive. So combining both those, the motility, total motility should be like around 40, and according to recent guidelines, it should be 42%. Coming to vitality, it is like 58, and recent it is 54. Next, next thing is morphology. Okay, it is 4% in both. Okay, in both editions. Next is round cells and leukocytes. So its concentration should be less than 1 million in both. Okay, less than 1 million, and round cells should be less than 5 million. Okay, so at most what like will give more importance to, first is volume, second is concentration, third is motility, fourth is morphology, and fifth only like round cells, leukocytes, and all those. Okay. So this is regarding semen analysis. Semen analysis will study in two portions. Like one is macroscopic and microscopic. So what we have discussed is till now is microscopic. Okay, in microscopic, what we'll see, what is the concentration? Okay, concentration. Next is agglutination, we can check. Third is motility. Okay, fourth is morphology. Next is vitality. All these will come under microscopic examination. Okay, concentration. So it is like 16 million per ml. Motility is 42% total motility, and vitality is 58%. Morphology is 4%. Agglutination is nothing but when sperms they agglutinate with each other. Okay, that is called agglutination. So generally, if it is more than 10%, then they might suspect, it is suspicious of some immunological problem. Okay, if there is any immunological disorder, there will be agglutination between the sperms, and that might be one of the reasons for infertility. Okay, next is macroscopic. Macroscopy is first is liquefaction. Second is viscosity. Third is pH. So first is liquefaction, viscosity, pH, and next is volume. Okay, as we have already discussed, normal volume of seminal fluid, it should be like around 1.5 ml or 1.4 ml. Okay, so suppose what is the reason for seminal fluid composition? Okay, usually sperms are produced in testes. Okay, they will travel all the way through epididymis, vas deferens. Then there it will get mixed with the secretions. Okay, most of the volume of the seminal fluid is contributed to by seminal vesicles and prostate, part of prostate. From there, it will enter into ejaculatory duct and there into the urethra. Okay, so most of the secretions will be collected from seminal vesicles, ejaculatory duct, and prostate. So suppose if the volume, normal volume, it should be like somewhere around 1.5 ml. Okay. Suppose if volume is less, okay, volume might be less or volume might be more, hypospermia. Okay, hypospermia is nothing but when volume is less, we'll call it as hypospermia. So what are the probable conditions? Any pathology associated with seminal vesicles, prostate, ejaculatory duct. Sometimes there may be obstruction at these areas. Ejaculatory duct obstruction, okay, seminal vesiculitis, prostatitis. Okay, if there is any obstruction, it might lead to less volume. Suppose if there is any infection, sometimes there will be less volume. And also in other conditions, whenever there is inflammation or there is infection also, it will produce more amount of secretions. Okay, that might lead to more volume of semen. So any pathology, any infection or inflammation related to these three organs, it might cause like volume disorders. Like it might be more volume, it might be less volume. Okay, next. Suppose in few cases, like there will be absence of vas deferens, congenital bilateral absence of vas deferens. So what will happen in such case? It is usually associated with underdeveloped seminal vesicles or absent seminal vesicles. In such cases, suppose if seminal vesicles are not developed or absent, so it will contribute to obstructive azoospermia. Okay, obstructive azoospermia, and volume also will be less. Okay, so suppose if there is any obstruction in the vas, volume will be normal only. Okay, count may be abnormal, but volume will be more because count is produced in spermatogenesis, everything will happen in testis. Suppose if there is any pathology in testis, then automatically sperm production will be reduced, but not the volume. If there is any problem both with the testis and with the like semen vesicles, ejaculators, everything, then both are compromised. Like sperm parameters will be less and volume will be less. Okay, and vice versa. You have to see. Yeah, see, if count is normal, that means testis is functioning absolutely. So, but the volume is less. That means there is pathology in the obstruction. So, somewhere there might be obstruction. Okay, that might be obstruction in the vas deferens also, but mostly seminal vesicles, prostate, and ejaculated duct dysfunction. Okay. Next is pH. So pH, it is usually between 7.2 to 7.8. It is alkaline. Okay, because seminal vesicles will produce fluid. It will contain more of basic compounds, and prostatic secretions will be little acidic. So because most of the secretions will come from seminal vesicles, so that's why seminal fluid is itself is alkaline. Okay. Suppose if there is any infection, seminal vesiculitis or infections of the seminal vesicles or prostate infections, obviously what will happen? It will become acidic. Okay. So the compounds will be degraded. No. Seminal vesicle contains composition is basic. Seminal fluid is composed by both prostate secretions and seminal vesicle secretions. Seminal vesicle secretions are basic. Prostate secretions are acidic. Suppose if there is any pathology in prostate infection, it will contribute to more of prostate secretion. So ultimately, what will happen? pH will become acidic. Okay. So in infections and inflammations, pH will be altered. Next is liquefaction. Normally, what is the time limit for liquefaction of the seminal fluid? 20 to 30 minutes generally, but few of the studies they will consider up to 60 minutes is also normal. Okay, so what is like at the initial state, whenever a male patient gives the sample, it will be like thick and viscous. Okay, but over a period of like around 15 to 20 minutes, what will happen? Okay, some enzymes will be there. It will act on the proteins. Okay, proteolytic enzymes will be there. So it will degrade the proteins. What will happen? Semen liquefies. Because if it is too thick also, sperm can't move inside. Okay, it will hinder the sperm motility. Suppose if it is very viscous.
క్లాస్ అవుతుంది 49.
Okay. Doctor, please mute yourself. Okay. So proteolytic enzymes will be there. It will cause liquefaction of the seminal fluid. So seminal fluid will become less viscous. As a result of which, it will have easy access. Sperms will have easy access for the sperm motility. Suppose if it is too viscous also, it will impair sperm motility. And if it is too thin also, it will hinder the sperm motility. Anything abnormality, like if it is too thin, if it is too thick also, both will have negative impact on sperm motility and sperm vitality also. Okay, so what will happen in like few infections also? The same thing. Okay, enzymes won't act. Proteolytic enzymes, everything which will come, basically all the proteins will come from prostate and seminal vesicles. If there is any pathology with these two organs, then ultimately there will be problem with liquefaction. And also in few of the seminal reports will be seeing liquefaction time is increased. That is more than 60 minutes. More than 60 minutes. Okay, what will happen? Suppose if as the liquefaction time increases, what will happen? Ultimately, the infertility rate also will increase. Because suppose if the same like male partner, if he has intercourse with the female partner, what will happen? As soon as the semen enters the vagina, it has to liquefy. Then only the sperms will enter into the uterine cavity. Suppose if it is very viscous, if it is very thick, then sperm can't move. Okay, the motility will be impaired, and ultimately it won't enter the uterine cavity, and there is no chances of natural pregnancy. So next, viscosity is nothing but the same thing. Okay, at initial state it will be viscous, thick, but slowly over a period of time, because of the mucolytic action of the enzymes, it will become less viscous, which will help in motility of the sperm. Okay, these are the macroscopic features. So whenever we see the semen analysis, okay, what we see is we'll concentrate only on the microscopic features, like what is the concentration, okay, what is the motility, vitality, and like what is the morphology, everything will concentrate. But also this thing is important. Okay, so we have to see that whether it is volume is normal, pH is normal, and what is the liquefaction time. Okay, till it is clear till now? So this is regarding the semen analysis. Okay, you go and read regarding semen analysis. Okay, WHO fifth addition and WHO sixth addition. What is the differences? You can make out. Okay. So these are the parameters which we concentrate while giving the semen analysis report. Next is hormonal evaluation. So hormonal evaluation is first is like basically pre-testicular. Next is testicular. Next is post-testicular. So pre-testicular is nothing but hypothalamus, problem with hypothalamus and pituitary. What will happen for both the hormones? FSH will be less. LH will be less. Okay. So what is normal FSH action? It is, okay, it will act on Sertoli cells, causes the spermatogenesis. Okay. And LH action is Leydig cells, testosterone. Testosterone, what will do? It will aid in spermatogenesis. Okay. It will help in sperm production. That is nothing but spermatogenesis. And also it will act on it will act on seminal vesicles and prostate to increase the prostate secretions and seminal secretions, which will contribute to seminal fluid. Okay, so ultimately, if FSH and LH are less, testosterone also will be less. So whenever you see a male patient with hypo, only basic treatment is give him, because internally hormone production is less. So that's why externally you have to give these supplements in the form of like HCG injections or recombinant FSH injections also you can give him. Hello? I should am in class. Isn't? Yeah, okay. No, I'll call you in 15 minutes. Okay, this is testicular. So generally, okay, first we'll discuss post-testicular. Post-testicular is nothing but what will happen? Testicular pathology, everything will be normal. Okay, there is no testicular pathology. Sperm production is normal, but coming to the pathway, there will be obstruction in the pathway, like vas deferens or seminal vesicles problem, or there is any ejaculatory duct obstruction, or sometimes there is congenital biliary absence of vas deferens also. In such cases, what will happen? FSH hormone will be normal, LH will be normal, and testosterone will be normal. Okay. Coming to testicular pathology, so FSH, it might be normal or it might be increased. Okay, whenever there is suppose Sertoli cell destruction, okay, suppose if there is grade 3 varicocele, or if there is any infection or there is any inflammation, what will happen? Testis gets damaged. So ultimately what will happen? Sperm production will be reduced and hormone will be increased. In such cases, you can see FSH is increased. But what about those cases where you can see FSH is normal, but the patient is like landed up in primary testicular failure? What is the reason? Can you name some conditions? Like where FSH will be normal, but he'll have azoospermia. There is no post-testicular causes. Okay, so simple thing is if FSH is elevated, that is clear-cut case of primary testicular failure. If FSH is normal, it might be testicular cause or post-testicular cause. If you do a scanning, okay, if you do a scanning report, it is absolutely normal. Seminal vesicles is normal, ejaculatory duct is normal, vas deferens, everything is normal. Okay, then you have to think regarding the testicular cause, because there are different stages of spermatogenesis. Okay, in few cases, FSH will act on the Sertoli cells, but there will be like normal time for spermatogenesis is around 72 days. Okay, so in this, there will be different gradings. Okay, there will be different stages. Like sometimes there will be maturation arrest. Okay, because FSH is acting on the Sertoli cells, but the pathway, like sperm production will be there, no? That pathway, that staging is altered. So because FSH is playing a major important role in the sperm production, but ultimately because of the maturation arrest, okay, what will happen? It will reflect as azoospermia, but where FSH will be normal. Okay, so stages arrest, maturation arrest. In such cases, we can see FSH hormone is normal. In primary testicular failure, sometimes LH might be, in few cases, LH might be increased because if there is any testicular destruction, what will happen? There will be decrease in concentration of decrease in concentration of Sertoli and Leydig cells. So FSH is increased, LH is increased, and testosterone will be decreased. But extremes, okay, Sertoli cells are there, Leydig cells are there. FSH is acting, LH is acting, and testosterone is also normal. But only thing is, like, there is a problem with the spermatogenesis pathway. Okay, that meiosis, everything will be there, no? There is some pathology with the staging. Okay, so here LH will be normal, testosterone will be normal. Okay, so in hypo simple, both are less. In post-testicular, all are normal. In testicular only, sometimes FSH might be increased. Most of the cases, FSH is increased. And few cases, FSH might be normal. Okay? Is it clear? This is hormone evaluation. Okay? Basically, only main thing is FSH, LH, and testosterone. And also sometimes other hormones like inhibin, costly, we can do. And your homework is what is the role of inhibin. Okay, inhibin and AMH in males. These two is like you go and read. What is the significance? And doctors, you should tell, one of you should tell me tomorrow. AMH, you'll be telling me, and inhibin B. Okay. Next is prolactin, thyroid hormone. Okay, because previously also we have discussed hyperprolactinemia and hypothyroidism. It will cause decreased FSH, LH and will affect the spermatogenesis. Okay, so this is all regarding the hormone evaluation. Main thing is FSH, LH, testosterone. Other things is inhibin, AMH, prolactin and thyroid. Okay. Next others is ultrasound. So ultrasound is first scrotal ultrasound. Ultrasound and Doppler. So first most important thing is varicocele. Grading of varicocele we can see. And also we can comment on position of testis, whether it is like cryptorchidism or not, we can see. First thing is cryptorchidism. Second thing is varicocele, whether there is any inflammatory pathology. Okay, if there is any inflammatory pathology, we can make some fibrotic changes in the testis or fibrotic changes in the epididymis or vas deferens. Okay, and in scrotal ultrasound, we can make a testis, epididymal pathology, and vas deferens. And transrectal ultrasound, TRUS. What we can see? We can see seminal vesicles, ejaculated duct, and prostate. So there is any prostatitis, any ejaculated duct obstruction, any seminal vesicle obstruction, or seminal vesiculitis. And also you can make out absence of vas deferens. Vas will be visualized in both transrectal and scrotal ultrasound, because the front part you can see in scrotal ultrasound and the back one. Okay, entry into seminal vesicles we can make out in TRUS. Usually congenital bilateral absence of vas deferens is usually associated with absent seminal vesicles or underdeveloped seminal vesicles. Okay, so this is ultrasound. Okay, scrotal ultrasound and transrectal ultrasound. And also one more thing, fructose. Okay, because fructose is the most important nutrient for sperm functioning. Okay, the fructose will be produced from seminal vesicles. Okay, suppose if there is any seminal vesiculitis or ejaculated duct obstruction, okay, there will be decreased fructose. Okay, so because fructose is produced from the seminal vesicles, any ejaculated duct obstruction or seminal vesicle pathology, absent fructose in the semen. And also congenital biliary absence of vas deferens, because usually it is associated with absent seminal vesicles only. In these three conditions, okay, ejaculated duct, seminal vesicle, absence vas deferens. In these three conditions, fructose will be absent. But if there is any pathology in vas deferens also, other than absent vas deferens, like vasectomy, okay, because it will be prior to, the obstruction is prior to seminal vesicles, no? Okay, so that's why any pathology with vas deferens or epididymis or testis, okay, fructose is present. Clear? Any doubt? See, ma, this is testis. See, seminal vesicles will be thick. Okay, seminal vesicles. This is ejaculated ducts. Okay, this is vas difference. Vas difference will open into seminal vesicles. Okay, seminal vesicles will open into ejaculated duct. Suppose if there is any fructose will be secreted from here. Okay, this is urethra. Fructose will be secreted from here. If there is any pathology with ejaculated duct obstruction or seminal vesicles, then fructose will be absent. If there is any pathology prior to this, like vas difference or epididymis or testis pathology, then fructose will be present, except in one condition where there is absence of vas difference, because it is usually associated with some absent seminal vesicles. That is the reason. Okay. So ultrasound finished, endocrine evaluation finished, and everything is finished. One more important thing is genetic evaluation. Okay. So genetic evaluation is karyotyping. Okay, karyotyping first. Second is Y chromosomal microdeletion. Y chromosomal microdeletion. Third is CF mutation. Okay, so usually karyotyping, what we can make out usually in severe oligospermic, like less than 5 million count, or oligospermia, severe oligospermia or azoospermia. In few cases, we can make out like translocations. Okay, some translocations we can make out, and also we can see Klinefelter syndrome also we can make out, because Klinefelter males also they'll land up in oligospermia or azoospermia. Next is Y chromosome microdeletions. See, there will be azoospermia factor gene mutation. Okay, in Y chromosome, there will be one area, azoospermia factor mutation. Suppose if there is any mutation in this gene, azoospermia factor gene, if there is any mutation in this gene, generally they'll present with oligospermia or azoospermia. Suppose if the mutation is in different areas, A, B, C. Okay, this is Y chromosome, this is azoospermia factor. Suppose it has 3 areas, A, B, C. If there is any mutation with A and B, generally they'll land up in azoospermia. If there is any mutation with C area, they'll land up in oligospermia. Okay, so that's why if any male is azoospermic, and if we do like Y chromosome microdeletions, then we can make out, like before doing ICSI, we can see whether there's any chances of getting sperms on sperm retrieval on TISA. Okay, suppose if there is any mutation in C region, then we can counsel the patient that there is chance of sperm retrieval. Suppose if there is any mutation in these two areas, we can't retrieve the sperms. There is 0% chances of sperm retrieval. Next, usually this is like non-obstructive azoospermia only will categorize. Suppose if there is any obstructive azoospermia, okay, what will usually in obstructive azoospermia, what will happen? Cystic fibrosis is there. Okay, why? Because in congenital absence of bilateral vas difference, okay, it will be associated with cystic fibrosis. Suppose cystic fibrosis is an autosomal recessive disorder. Okay, so if male is a known case of azoospermia, obstructive azoospermia, okay, we have to check cystic fibrosis gene. Okay, suppose if he's positive, then we have to check the same thing for female partner, because if female partner is also carrier for cystic fibrosis, then there is a chance of getting the baby with cystic fibrosis. So that's why in obstructive, suppose karyotyping, when do you suggest? Whether he is azoospermia or severe oligospermia, better to do karyotyping to rule out some translocation abnormalities or any syndromes like Klinefelter syndrome. Suppose if it is obstructive azoospermia, then cystic fibrosis chances will be there. Okay, so that's why, like especially if there is absence of vas difference obstructive azoospermia with absence VAS difference, then only have to get CFTR gene mutation done. Next thing is non-obstructive azoospermia, that is related to testis pathology. So Y-chromosomal microdeletions, and also it helps in identifying the cause and also identify the success rates on TISA. Okay, so this is related to genetic testing, and also there are some other tests like semen culture test, semen culture, DFI, sperm DFI, and sperm chromatin function test. Usually it will be dealt in separate class. Sperm function test. Culture is nothing but if there is any infection, we can make out, and accordingly antibiotic course we can suggest to the patient. DFA is nothing but suppose in unexplained infertility or in patients with recurrent implantation failure or recurrent abortions. So where everything is normal, female factors, everything is normal, and even male also seminals, everything is normal. Just getting a DFA done will rule out the reason for infertility or these mishaps. That is, DFA is nothing but DNA breakdown, DNA damage. So they'll have some special tests like tunnel test or sperm chromatin function test. These are the three tests. By performing these tests, we can know the sperm DFI. If normal DFI should be less than 15. 15 to 30 is average, more than 30 is too high. Suppose if DNA damage is too high, okay, then we have to give him antibiotics, antioxidants, and we have to find out what is the cause for high DFI. Whether it is because of age, whether it is because of infection or because of varicocele, everything. We have to first treat the underlying pathology, then proceed with the normal treatment. Okay? Clear? So this is all regarding infertility, evaluation in male infertility. If any doubts, you can ask me.